Hi, everybody. My name is Lauren Puckett. I'm one of the antimicrobial stewardship pharmacists at Lucille Packard Children's Hospital. I'm extremely excited to introduce our SURF members who are partially here, but I've been extremely pleased with the work that our team with Shruti and Yi and Dr. Torsten Jorger, our Associate Medical Director for our stewardship program, have been able to address our project, which is about the discrepancies in antibiotic prescribing between inpatient and outpatient at that transitions of care. It's not just a problem that is for our hospital, but certainly something that is a national issue that we're now all starting to look more into. So really excited for not only the implications of what our team was able to find for this hospital, but what this could mean for other hospitals nationwide. And I'll hand it over. Thank you very much.
Good morning, everyone. I'm very excited to share our work on discharge antimicrobial prescriptions at LPCH. And before we begin, I want to give a huge thank you to our sponsors, including the Antimicrobial Stewardship Committee, as well as the teaching team for all the guidance and support they provided us through this project. So to give a general overview, patients at LPCH, when they're being discharged from inpatient care, they often receive antimicrobials, and the Antimicrobial Stewardship Committee reviews these prescriptions. If the ASP identified recently that 20% of these antimicrobial prescriptions ordered during transitions of care is suboptimal. What this means is that there is some discrepancy between the prescribed formulation, dose, frequency, duration of an antibiotic from what is recommended by the ASP. Antimicrobial stewardship has been critical for improving patient outcomes. In 2021, 80% of the time that the ASP retrospectively reviewed a prescription and recommended a change, the change was accepted. However, discrepancies still slip through the cracks. More than 50% of the time, although the ASP deemed that a change was necessary, the change was not recommended. And a lot of times this happens because the patient has completed the course of the antimicrobial before the audit has even occurred. And when this happens, discrepancies can lead to poor patient outcomes. To give one example, a 6-year-old boy was discharged recently on 2 incompatible IV medications, which ended up resulting in his central line being clogged and required readmission and surgical removal of the line. These are unfavorable outcomes both for the patient as well as the hospital. And for every one kid that suffers such severe consequences, there are 10 others that are facing some milder discomfort through these prescriptions. So our project aimed to really understand this problem and identify the drivers of the discrepancies in these discharge antimicrobial prescriptions and provide certain solutions. And we did this by analyzing prescription data from December of 2021, and also conducting stakeholder interviews. In the interest of time, I'll focus on one key finding, which is that augmentin is one of the major drivers of discrepancies, both by volume and by the percentage. 40% of augmentin prescriptions have some discrepancies. And to provide some context, augmentin is one of the most commonly prescribed broad spectrum antibiotic, and high doses of augmentin can cause gastrointestinal side effects like vomiting and nausea, and too low doses can result in failure of treatment. We wanted to explore augmentin further because it also came up consistently in our stakeholder interviews as a drug that is really difficult to prescribe. And as we try to understand the reasons for that, we learned that the first thing is there are several different formulations of augmentin that are available based on the amount of amoxicillin and clavulanic acid that's in the drug. And with each formulation, the dose and frequency changes, which is recommended. Now, there are guidelines such as lexicon that you see here in this screenshot that providers refer to, except they're very time-consuming and difficult to look through. And often there are inconsistencies in the way these guidelines are provided. And for example, if providers using a mg per kg per day guideline and writes a prescription of 40 mg per kg per dose twice daily, then they'd end up giving the patient twice than what is recommended. And also there are inconsistencies in the inpatient and outpatient prescription ordering process, which could also be causing some confusion. So as we explored Augmentin further, we saw that of the 229 prescriptions that have some discrepancy, 63% were those where Augmentin was ordered for prophylaxis and 37% for treatment of infections. We wanted to focus on this 37% because while the optimal dosing for prophylaxis is more based on the provider's clinical judgment, for treatment of specific infections, there are very clear guidelines on what is the recommended formulation, dose, and frequency, which we recognize that this logic could be read by an algorithm. So we developed an indication-based algorithm that can read the indication and patient weight, then identify the recommended formulation, dosing range, and frequency, and then compare this with what was ordered. And we were able to tag the discrepancies using this algorithm. And then to validate the algorithm, we compared our results with the ASP auditing data. And we found that about 90% of the time, our algorithm was able to reproduce what the ASP audit did. 74% it was an exact match, and 16% we identified there were some errors in the audit documentation. The 10% of prescriptions were where there was more clinical judgment involved in the auditing process, which could not be captured by our algorithm. So with 90% accuracy, our algorithm could be a very useful tool for faster and more efficient audits, except one limitation is that it cascades starting from indication. And indication is currently not a part of the prescription order itself. And the ASP is identifying the indication from the patient chart and the patient notes. So to overcome that, as well as have this tool be more proactive and tackle the problem at the root, we propose that this can be made available as a real-time prescription support for providers themselves while they're ordering Augmentin. All the provider would have to do is input the indication and the patient weight, and they'd have a recommended dose, formulation, and frequency. In addition, we would also provide the formula and the calculation as well as references to guidelines so that providers are able to trust this algorithm as well as engage in some learning. And we think this can be easily integrated into the current provider workflow. As you can see in a screenshot of Epic here, providers typically click on the link to LPCH house staff manual at the top, which they refer to look through the guidelines and calculate the order, dose, frequency, etc., before they come back and input that into Epic. We propose that we add a link to our calculator, which providers would just have to click on in a similar fashion, input indication and weight, get the recommended results, and come back and input into Epic. Such real-time prescription support will benefit all stakeholders across LPCH and the patients. It'll improve speed and efficiency for providers by avoiding any human calculation errors. It'll improve hospital resource utilization and quality. It'll save time for ASP pharmacists, reduce adverse outcomes like readmissions, and improve patient satisfaction. And ultimately, it's going to improve outcomes for patients, prevent treatment failure, reduce side effects, and improve medication compliance. So in conclusion, we found Augmentin is one of the drivers of discrepancies, and these discrepancies, particularly for treatment of infections, can be prevented through a simplified ordering process using an automated algorithm. And with Augmentin as one use case and a specific example, we feel that it's a good proof of concept showing that real-time prescription support can be provided to improve discharge antimicrobial prescriptions overall, as well as maybe other pediatric prescriptions in all care settings. For next steps, we're looking at piloting this tool and getting user feedback so that we can iterate on the design and functionality. We are also exploring expanding this real-time decision support to the whole prescription as well as other antimicrobials, and also exploring the use of this tool as real-time audit support for the ASP, the pharmacy, and their trainings. Thank you, and happy to take any questions.
Before we go, I just want to make a comment. This work is fantastic. I know you who couldn't be here because of a prior commitment, and the sponsors worked really hard. It's also incredibly impressive that you all did this in just weeks with the interruption of the labor strike, where even up towards the end of the project, you were still developing this deep understanding at the clinic, why things weren't always clear, and then to put all of that together and to size that into an actual proposed an intervention that could be examined and tested for this more broadly applied. It's wonderful, very impressive work.